Good morning and welcome to Southern Maine Healthcare's Medically Speaking. I'm your host, Robert Erickson, and for the next 30 minutes, you'll hear about medical issues and topics of the day directly from leading medical professionals at Southern Maine Healthcare. My guest today is Dr. Brandy Wingard, a board-certified and fellowship-trained cardiologist at SMHC Cardiology. We'll be discussing things you should know about heart health. Welcome, Dr. Wingard.
Thank you for asking me to be here. I really enjoy being here today to go over some information about cardiology.
So tell us a little bit about how you got into cardiology coming out of college.
Well, initially I thought I was going to do primary care, but as I was going through my residency, one of the rotations was with cardiology. The thing I really liked about cardiology was the fact that the ability to treat people and the recovery rate. People come in with heart attacks, and nowadays they can get stents and be home within a few days. We've got great medical management for patients. The other thing I do like about it is that not only do I get to see patients in the office, but I can also do procedures and have some time in the hospital too. So it's a great sense of balance.
So how challenging is it to be a specialist like this? Do you have to go back to school to learn additional techniques, et cetera?
Well, the initial process is quite long. It takes 14 years between your undergrad, your medical school, residency, and then your fellowship. But you do have conferences throughout the country. You're supposed to attend so many over a period of time to kind of keep yourself updated on the latest technology.
What sort of trends are you seeing in cardiology? Are more people experiencing heart problems?
Unfortunately, yes, more people are having more cardiac disease. Secondary to, unfortunately, the obesity epidemic, more people are overweight, and that is playing a huge part into it. The other factors that play a part into it is smoking. People are still smoking, and that definitely increases your risk for cardiac disease in the future.
So what sort of trends are you seeing in your practice here on a local level?
Definitely, there's unfortunately secondary to this obesity factor that increases people's risk for high blood pressure, diabetes, high cholesterol. And those three factors are really your major factors that can set you up for disease. We do see a lot of coronary disease. That's the disease in your coronary arteries. Basically, over time, fats can deposit, causing the hardening of the arteries, setting you up for heart attacks. And we do see that a lot around this area.
You hear a lot about symptoms of heart attacks. What should the average person be on the lookout for in terms of those symptoms, and what age groups are we talking about?
So in terms of symptoms people have, we do have a certain percentage of people that always have the classic having chest pressure on the left side of the chest. Sometimes it radiates to the arms. Sometimes people will just have jaw pain. They won't even have chest pain. And especially in women, they unfortunately have not the typical chest pain on the left side with pressure. Sometimes it's on the right side. I've seen a lot of patients who've actually thought they were having bad reflux, a little bit of heartburn, so that's another concern. And on top of that, I've had some women who just present feeling really fatigued. They can't do what they normally do. They feel pretty sweaty, and they present and find out that they are having heart disease.
So what do you do as a cardiologist to evaluate them when they come in?
So initially, they usually come in through the emergency room. I'll see them there, or sometimes they call the office and I'll see them as an outpatient for a consult. What I look for is their symptoms that they're having, how often they're having it. Are they having it with exertion? I also look at their risk factors. What type of risk factors do they have? Do they have a family history of this? And then after we have this discussion, then we decide if it's high risk, do we need to proceed with a catheterization to look for disease in your coronary arteries, or do we start with a stress test first?
So walk us through the process. Let's say a patient comes in, male, 60 years old, complaining of chest pains. Well, walk us through the procedure you go through.
So initially, I'll go ahead and interview them, find out some information about them. We do an EKG to look for certain changes on that. Some people will have changes that suggest that they are having a heart attack. If besides that, we also take blood work. There is a thing called a troponin, which is seen in your blood work. We can pick that up in it when your heart is having stress or having a heart attack. That will be elevated in the blood. It's usually elevated 4 to 6 hours after the initial onset of your symptoms. So we do check that, your EKG, and then depending on what we find, we will pursue with a stress test.
So explain an EKG. That's a term that everyone's familiar with from TV shows. What is an EKG?
Yep. So basically, an EKG looks at your electrical activity of your heart. It will, there are leads that they put 12 leads across your chest area. It actually helps to locate certain positions of your heart to determine what area we may be concerned that you are having the heart attack from. It gives the activity of when your electrical system goes from the atrium to the ventricle to present its beat. And depending on the type of chest discomfort you're having, we can see certain changes on that that's from a baseline normal that we see in most people that may give us some evidence that you may be having a heart attack and what location.
Are these kinds of symptoms of heart disease, are they different for women?
So with women in general, they may have or maybe having symptoms that are not typical, as I said, with men. Unfortunately, they do wait. They tend to wait longer before they get help because they think they couldn't possibly be having a heart attack because they're not having the chest pain. But unfortunately, it is the number one killer in women. So we do encourage women, even if you're not, if you're really not having chest pain, but you're not feeling good, to seek medical attention right away. So with women, risk factors is a big thing, and how they're telling me the story. If they said, last week I could walk 3 miles, and suddenly today I can't, I can barely walk across the kitchen. I can barely do what I normally do. I'm having increased shortness of breath. So certain symptoms, I put it in context of what they were doing and how their lifestyle is different right now.
We see a lot of ads on TV aimed at older people about AFib. What is AFib, and what are the symptoms, and what is the worry?
So with atrial fibrillation, unfortunately, it's something that people can get as they get older. So if you're 80, you have a higher risk of getting it than when you're 70 and so forth. The concern with atrial fibrillation is that atrial fibrillation in general is a disease of your electrical system. Just because you have atrial fibrillation doesn't mean you're having a heart attack, which a lot of people think that when they hear that they have atrial fibrillation, that's going to set them up for a heart attack, which is not the case. Atrial fibrillation is strictly to do with your electrical system. The one problem with atrial fibrillation is that it does increase your risk for stroke. And so we usually put our patients on some type of blood thinner to help decrease the risk of clotting, to decrease their risk of stroke in the future.
Now, explain to the average person the difference between a heart attack and a stroke.
Yep. So for heart attacks, we're talking about having blockages in your coronary arteries. And your coronary arteries are the arteries that supply your heart with blood. So if those become narrowed over time or blocked, it causes you to have a heart attack, chest pain. And so what needs to be done is to have a procedure to go in there to open up the vessel to restore that blood flow. In terms of a stroke has to do with the brain. So in terms of either it's a clot or there's one of your vessels in your brain that start to bleed that cause people to either lose weakness in an arm, a leg, to have visual changes. But with that being said, stroke and heart attacks, they both have similar risk factors, and we kind of, in terms of decreasing your risk, we look at the same things like high blood pressure, cholesterol, and smoking.
So let's say someone comes in and they have blockage and it's determined that they need additional care. Is that work done at Southern Maine Healthcare?
So if we determine a patient needs to do a catheterization, we go ahead and do that procedure here. We do diagnostic catheterizations, which is usually a day procedure. If I see a patient in the outpatient setting, I'm concerned that they may have some blockages in their coronary arteries. I set them up as soon as possible to come to our hospital to go ahead and perform this procedure. The procedure can be done either two ways. One, through the radial artery, which is the artery in the arm, or the second way is the femoral artery, which is down in the groin area. This past year, we were able to start doing this procedure through the wrist, which is great for the patients. What that entails is actually the patient coming into the room. We numb up their wrist area. We get access to the artery, and we're able to pass the catheters into your heart. At that point, we'll shoot contrast through those arteries and are able to take pictures to determine if any of those are narrowed or blocked. Of course, you get conscious sedation with that, so you're very comfortable, or you're either sleeping through the process. Patients love this procedure more than going through the femoral artery or the groin area, just because of the recovery time afterwards. The way we used to do it through the femoral artery, people would have to be flat for like at least 4 hours. It's a larger vessel, so there's more maintenance with it. With the wrist, people are up in their room, sitting, eating right after the procedure. It also, I explained to patients that there's decreased risk of complications associated with it, in such that since the artery in the arm is smaller than the artery in the leg, it decreases your risk of bleeding, decreases your risk of vascular complications, meaning problems with your arteries or nerves associated with it. In general, studies show that greater than 90% of patients prefer that method versus the leg method.
So it seems like with a lot of these issues of the heart that it's a call for the patient. They need to know when to come in. What advice would you give for someone who is feeling discomfort?
So in terms of coming in to see a physician, unfortunately people delay. And the biggest problem with people having heart attacks is the faster that we can get them here, get their vessels open, or treat these people appropriately, this decreases the risk of complications later. So I always tell people, if you're having chest pain, if you think something's off, seek medical attention right away. Don't delay it. A lot of people feel like, oh, I don't want to bother anybody. I'm sure it'll go away. I'll talk to somebody later. Don't do that. Just come to the hospital and get the medical attention you need. Also, if you've had a history of it, or you do have the risk factors that we've talked about, you have a very low threshold of calling and getting help. The other thing I want to say is that if you feel like you are having a heart attack, call 911. Don't drive yourself. We've had patients who drove themselves to the emergency room, or they've had friends bring them in. Call 911 and have an ambulance bring you in.
Do you have an example of somebody maybe who made a decision to seek care and it made a significant difference in the outcome?
Yeah. So I had a gentleman in his 60s with multiple cardiac risk factors, thought he was having just bad reflux. He could relate. He had pizza one night, he had some beer the next day, and he just assumed he was having bad reflux. But unfortunately, the pain in his stomach kept getting worse. He finally came in to get evaluated, and he truly did have coronary disease. He had some narrowing of his artery. He was able to get the diagnostic catheterization done here at Southern Maine, and then he was sent to Maine Medical Center for proper treatment of that.
So what is the procedure if someone comes in and they need catheterization, when they need additional surgery? Walk us through that scenario.
So once we do the diagnostic catheterization, which is basically taking pictures of your coronary arteries to determine which artery is narrowed or blocked, we then have a discussion with the physicians at Maine Medical Center. They're able to view our pictures very quickly later that day. I have a conversation with them discussing the patient and seeing if it's possible for the patient to have a stent placed in that artery. The process through that is similar to the initial diagnostic catheterization, where they can go through the arm for that, and they're able to go in, take a balloon, open up the vessel, restore blood flow, and then they place the stent there to maintain that the vessel will stay open. I tell patients the stent is in some ways similar to like a little pen spring, in terms of trying so they can have a concept of what that means. There's different sizes, and depending on the size of your vessel, they'll use that size.
So once someone has a stent, does that increase the likelihood of them having an incident in the future?
No, it doesn't increase their risk of having problems in the future. Patients ask me a lot of times, once I get the stent, do I have it forever? And that, yes, you do. Patients who are compliant with their risk modifications and their medications actually do very well. And just because you had one stent doesn't mean you have to go back again or ever have a cardiac event again.
You're listening to Southern Maine Healthcare's Medically Speaking with Robert Erickson. My guest today is Dr. Brandy Wingard, a board-certified and fellowship-trained cardiologist at SMHC Cardiology. And we'll be right back with Dr. Wingard in just a moment.
Not every boo-boo is an emergency, but it still feels like one. That's why Southern Maine Healthcare offers walk-in care. You'll find compassionate care at wonderfully convenient locations. Open 7 days a week, no appointment necessary. For those times when the unexpected happens, or you're just not feeling great, look for the orange ball as your sign of the best walk-in care. In Kennebunk, Saco, Waterboro, and Sanford, Southern Maine Healthcare, a member of Maine Health.
We're back with Dr. Brandy Wingard. Now, Dr. Wingard, another thing we're doing at Southern Maine Healthcare that's a little unusual is the use of pacemakers, and you bring that new skill here. Tell us a little bit about the implants and pacemakers.
Yep, as of January of this year, we're doing pacemakers here at Southern Maine. Apparently, they were doing pacemaker years ago, but we've restarted that. In terms of pacemakers, pacemakers are used for patients who are having issues with their electrical system of their heart. I first see these patients usually when they present they feel very dizzy. They have passed out multiple times. We've done a workup on them. And found that their electrical system isn't working as well as it should. And what I mean by the electrical system is when the way the heart is supposed to beat is that the atrium, the top part, tells the ventricle, the bottom part, when to beat. And when there is some type of interruption in that conduction system, people will start to have symptoms, and that's when they need a pacemaker.
Okay, so tell us about how that's put in. What is a pacemaker?
So a pacemaker has a couple components. One is the actual generator. We call it the generator. It contains the battery, and it also contains the programming information. It is placed underneath the skin, usually on the left chest area, and connected to that generator are leads. The leads then are taken from the generator and placed into the heart. Most people get 2 leads, one for the atrium and one for the ventricle. These leads are able to sense if your heart beats, and if it doesn't, it reminds it to beat.
Let's talk about the heart itself. It's obviously very complex. As you've gone through school and studied these issues, what do you find particularly fascinating about the working of the heart?
The heart, as you've mentioned, is very complex, and in terms of the multiple disease processes for it, it's amazing. You have, we've talked a lot today about the coronary artery disease for heart attacks, but there's also the electrical system, which we've touched briefly on in terms of needing pacemakers. There's also the valves themselves. You have 4 valves in your heart, and either some people are born with an abnormal valve, or over time, unfortunately, they can calcify, and people do require valve replacement later down the line. The other issue with the heart is that people can have cardiomyopathies. That tends to be another thing we see a lot around here too. Cardiomyopathy is basically when the heart doesn't pump as well as it should. And we can diagnose that on echocardiograms, which is an ultrasound of your heart. We can see if your heart is beating appropriately. There's a lot of diseases that can cause cardiomyopathy, so we do see a variety of people here in this area with cardiomyopathies.
So the heart is a muscle. How can people strengthen the muscle to avoid problems in the future with their heart?
So in general, because of the technology we have today, for instance, if a patient is diagnosed with a cardiomyopathy, the weakening of that muscle, we do extensive workup to determine what caused that. And if we can find what precipitated that by fixing that culprit, sometimes people's heart function will improve. For instance, one of the biggest things that you see is people have coronary disease and they didn't know it. So we go in, we fix that either with surgery or placing stents, and that helps to either restore or maintain the heart function as it is. We also have great medications these days, which we actually can place people on, and that does help improve their heart function.
So people can exercise all their lives and take care of themselves, but genetics still play a role.
Yes.
So what are some of the risk factors for heart disease? What can people do to strengthen their overall heart health?
So you're right. Unfortunately, we can't change our family history, but genetics does play a huge part in cardiac disease. But there's 4 other things that we do look at that I tell people to focus on that still will be able to help decrease their risk. One of those is smoking. Smoking is very big in terms of causing heart disease. A lot of people know that it causes lung disease, lung cancer, but in reality, it does affect your coronary arteries. Those are the arteries that supply your heart with blood that can cause heart attacks, and it does affect them tremendously. By stopping smoking, people actually help decrease their risk. Another thing is high blood pressure. So unfortunately, some people are genetically predisposed to have high blood pressure. But a lot of people have high blood pressure because they're overweight. And so I encourage people to be at their ideal body weight, to exercise on a regular basis, and also to have a low-salt diet. The third component would be high cholesterol. Again, high cholesterol can be genetically predisposed. I do have patients who are at their ideal body weight. They exercise, they eat healthy, but they still require some type of a statin or a medication that will lower your cholesterol. The cholesterol issue can be pretty complex. We do have, specialists throughout who just work with cholesterol because there's different components of that. The cardiologists in general like to look at the LDL. The LDL is your bad cholesterol. That's the part of it that builds up on your arteries and causes the plaque that can lead to heart attacks. So in general, we try to get that as low as possible, under 70. Another thing they look at is your HDL, which is your very good cholesterol. And people can increase that by, good exercise. And the HDL helps to get rid of the bad cholesterol. So we look at that number also. And then another one we look at is your triglycerides. And people, by eating low sugar diets, staying away from the alcohol, the candy, the chocolate, stuff like that, can help decrease their risk of high triglycerides.
So you've obviously dealt with people who've been athletic their whole lives and maybe they have a heart attack. How do you deal with the emotional side, or can you deal with getting them back to emotionally feeling that they can continue their lives as they have been?
Yes, I always tell patients that our goal in cardiology is to get you back to where you were before. And it's very common, patients after they have a heart attack, they're very in tune to their body now. So any type of chest discomfort, feeling somewhat off, I encourage them, come in, see us. We can evaluate you. If we need to proceed and do further evaluation, we can, or sometimes it's just reassurance. But I tell them have a low threshold of seeking help. But it's very common after I see the patient, after they've had the heart attack, they've had the stents placed, in follow-up, that they're very anxious about their new diagnosis and what that means going forward. We do have a very good cardiac rehab center here, and I encourage patients to do that. It allows the patient to actually start exercising again while being monitored, and it helps to rebuild that confidence that they can go ahead and do what they were doing before. On top of that, they're in a room full of patients who've had some type of heart disease. And, it does help to talk with people who've gone through what you've gone through. So I do try to address that when I see them.
Do you see different issues between men and women in how they deal with this?
In general, I think everybody, once they're done, is worried. I have some people who will have this procedure done and get back to their life right away. They want to get going, and then I have most of the people are very anxious. But I think both male and females, approach it the same way.
So if someone has had a heart attack and they've had the correct procedures, what's the follow-up plan? Do you see them regularly? How do you follow up with someone like that?
I do follow these patients on a long-term basis. Initially, after they've had the heart attack, we'll see them in the office within a couple of weeks afterwards just to see how they're doing. And then I extend it out. We'll go a couple more months. By that time they finish cardiac rehab, they're back to work just to see how they're doing. And then you go a little bit farther. If people are not having any symptoms, they're doing well on their medications, then we may move it to 6 months. And then after that, we can, depending on the patient, it can be every 6 months or it could be once a year, depending on the other issues they have with it.
Can someone live a better life or a healthier life after a heart attack?
Some patients do. Some patients, it's a wake-up call for them, and they actually do. They start working out, they lose the weight, their blood pressure gets better, their cholesterol gets better. So some people will go ahead and use this as something that, I don't want to continue down this pathway, and they do change their habits.
Is there any reason that they can't live a long, healthy life after a heart attack?
At this point, we know a lot about heart attacks, what causes them, and how to treat them. So people, after they've had one, if they're compliant with their medications and they work on the risk factors, they can live long, healthy lives.
Dr. Wingard, people get all sorts of conflicting advice about heart health. Take a baby aspirin, fish oil, flaxseed. What do you tell patients who come in and need advice about these issues? Some people might say, well, I heard you're supposed to take baby aspirin. Others say maybe not. How do you counsel patients in this regard?
So in terms, patients should do initially what their physicians want them to do. Some people have contraindications to that. But in general, things that we do know about is fish oil. There's studies that have been done with fish oil, and I do encourage people who have high triglycerides and issues with their cholesterol panel to go ahead and take fish oil. Fish oil is similar to if a patient can eat tuna, trout, or salmon throughout the week at least 3 times, that would cover the same as fish oil. Unfortunately, sometimes our diets aren't as good as that. So fish oil in general is usually safe for the patient and well tolerated. In terms of baby aspirin, it's always very controversial in terms of who gets aspirin and why and what the dose is. But in general, the patients that I see with the cardiac risk factors, I do have them take aspirin 81 milligram once a day. Research in the past few years have shown that aspirin 81 in terms of treating cardiac risk factors is just as good as 325. Prior to that, we were placing everybody on aspirin with 325 after they had a heart attack. But what they found was that in general, you just have higher risk of stomach issues or bleeding on the 325, and with the same effect, the 81 has the same effect as the 325. So I do encourage patients to take that. But again, you should talk with your physician, make sure you don't have any contraindications to any of those medications before starting it.
So just to summarize, as we get towards the close of the show here, why is it important to act quickly if you feel like you're having a heart attack?
The reason why we want patients to act quickly is that the longer your vessel goes blocked, or it causes increased damage proportionally to your heart. So if you wait hours to get help, that's been hours that a certain portion of your heart has not been receiving the blood it needs, and can lead to cardiomyopathies, which is the decreased heart function over time. So if you can get to the emergency room right away and they can diagnose that and get you to the proper place to enable you to undergo a procedure to restore that blood flow, that does decrease the risk of damage to your heart.
And with regard to pacemakers, tell us a little bit about the different types of pacemakers that are in use these days.
So in terms of pacemakers, there's the simple pacemaker that requires just one lead in the heart, and that depends on the reason why you're getting the pacemaker to determine if you get one lead versus 2. The other indicator is that there are even high specialized pacemakers called biventricular pacemakers, and those are for people that have other problems with their heart, like cardiomyopathies, that end up getting biventricular pacemakers. But in general, the general person will get a 2 lead pacemaker. This pacemaker usually lasts anywhere from 8 to 12 years. It depends on, in general, how often you use it. There's a battery, so if you tend to be requiring to be paced 100% of the time, your battery is going to be more 8 to 10 years, rather than if you only use your pacemaker 25% of the time, then it'll last obviously much longer.
So tell us a little bit about the loop recorder and the home monitoring systems you use.
So another procedure that we do here is implantable loop recorders. Those are the size of basically your thumb. It fits right underneath your skin. And you can wear it for a couple years. We place this in patients who have passed out. We're not quite sure why they're passing out. It monitors your heart rate and rhythm over the 2 years. We can take it out sooner if we need to. This is done through our device clinic. I have someone who actually helps me in terms of monitoring patients. Either patients can come to the office and we can download the information with our computer system to see what's been going on, if the pacemaker is working fine, or even the loop recorder, what type of rhythms are we seeing. This is also can be done too at home by phone. So we set you up so every 3 months you basically download it through your phone system. It's transmitted to our computer so we can determine what type of information has been going on with your heart. The only thing we can't do is actually reprogram it from our office. You have to come in to do the reprogram. But in terms of following your pacemaker, this is done easily at home.
So you're doing these procedures right here at Southern Maine Healthcare in Biddeford?
That's correct. We started doing these procedures January 2014 here. The community loves it. We've been able to, all the feedback from all the patients around here, they're just happy that they can come here to the Biddeford campus and be able to get diagnostic casts through the wrist done versus pacemakers, generator changes, instead of having to drive up to Portland. It really helps the patients out here.
Well, thank you, Dr. Wingard. It's been great talking to you, and we appreciate your time today.
Thank you very much for having me.
Well, we've run out of time for this week. My guest today has been Dr. Brandy Wingard, a board-certified and fellowship-trained cardiologist at SMHC Cardiology. Join me next week at this time for a new guest and an enlightening discussion about healthcare in our communities, brought to you exclusively by Southern Maine Healthcare, your trusted resource for healthcare in Southern Maine.